decided to do my presentation over pulmonary surfactant and its functions. My name is Antonia Harris. This is for Grand Canyon University for the class of Concepts of Human Physiology 2. So just kind of a little bit of background on surfactant. It is a mixture, it's a complex mixture of protein and lipids. And it's secreted from the type 2 alveolar cells. So the function of it goes in between the water molecules in the fluid lining of the alveoli, and it decreases the alveolar tension. Surfactant? The term surfactant comes from surface active agent, and the whole function of like I said, the whole function of surfactant is to reduce surface tension. If there's a lack in surfactant, it causes respiratory distress syndrome, but I'll get to that later. So a little bit more on surfactant and like its functions. So when it decreases the surface tension, that in turn increases pulmonary compliance, and it decreases the work that you have to put in order to inflate your lungs. And so it does this by decreasing the tendency for your lungs to completely deflate. That way they don't readily collapse, and like they don't recoil as much, so it's easier for you to breathe. When there is a lack of surfactant, then the transmural pressure gradient is gone, and that creates more tension, and that is why it's harder for you to breathe. When surfactant is present or given, because there is a supplementary version, when it is given, then it helps maintain the stability of the lungs. So surfactant decreases the surface tension, and then the surface tension, the decrease in surface tension is, it happens, okay, so the decrease in surface tension happens more in the small alveoli of the lungs versus the larger alveoli of the lungs. It's more effective in the small alveoli of the lungs because there's less space, so the molecules are closer together, so it's more effective, versus when it's in the larger alveoli of the lungs. The molecules are more spread out, so therefore it's less effective. So when it's present in less space, when there's less space, then it's more effective. So it helps stabilize the size of the alveoli, and it helps keep them open. That way they can actively participate in gas exchange, versus if they were closed, they would not be able to participate in gas exchange. Most of the times it's given during respiratory distress syndrome, so now I'll get into that. So respiratory distress syndrome happens when there is low levels of pulmonary surfactant present. It mostly happens when when a baby is born prematurely. It usually affects between 30,000 and 50,000 newborns in the United States every year. So basically, during respiratory distress syndrome, the baby has not matured enough or developed enough to produce enough pulmonary surfactant on its own, and their muscles are also weak in their lungs. So there's a lot of tension on that transmural pressure gradient. So it makes it really hard for them to breathe. Also, when they are breathing, because of that lack of surfactant, it's basically like their lungs are completely collapsing. Their lungs are basically completely collapsing, and they're trying to blow their lungs up with each breath. So they're blowing it up from start. So that's where the balloon inflation comes from that Sherwood mentioned in the book for the class. Basically was just saying, like, when you're blowing up a balloon, that first breath is always the hardest. And then once you get air into it, it's way easier. So when a child when a child has respiratory distress syndrome, they are basically starting from that first breath every single time that they breathe. So that alveoli of the baby is almost completely collapsing or recoiling with each breath due to that lack of that surfactant. And of course, it's harder to inflate a completely deflated lung versus one that's partially inflated and easier to contract. So usually when normally, um, it the transmural pressure gradient takes between 20 to 30 mmHgs. I mean, no, I'm sorry, 4 to 6 mmHgs. However, when a baby has respiratory distress syndrome, it takes 20 to 30 mmHgs, which is what, 5 times more than normal. So just imagine like being newborn, underdeveloped, and then trying to inflate all this stuff using all of this energy when your muscles are so tiny and so weak because you're brand new into the world. So that's just a lot of stress on the baby. And if you can't and if it gets too bad, it can lead to death if it gets too exhausting for the baby and like their muscles give out. um So, in order to kind of prevent that from happening, a corticosteroid can be given to the baby, given to the mother, um, between 24 and 34 weeks gestation to decrease the likelihood of the development of respiratory distress syndrome. Um, some of the symptoms that kind of alert doctors to the fact that a child may have respiratory distress syndrome after they're born are apnea, which was mentioned in the article that I read, nose flaring, poor feeding, ta- tac- ta- tachypnea, which that is where the baby's having 60 breaths per minute, I believe. Um, Let me see. Yeah, more than 60 breaths per minute. There's also cyanosis and grunting is also a symptom. Um, Usually, in order to treat it, a baby's put on oxygen, ventilation, and of course, the pulmonary surfactant is given. However, if the baby gets like an infection or something like that, it can cause a pneumothorax, which we discussed earlier this week in class, and a chest tube has to be given, and then the baby has to be given antibiotics in order to help with that infection, and then of course the chest tube is kept in until there's no more air that comes out of it, and the baby can heal, and they can take them off the chest tube. What else? Hmm. Oh, also, what I learned from my article that I read was that respiratory distress syndrome is more common in newborn boys versus girls, and it is 6 times more likely to occur in newborns whose mothers have diabetes. Yeah. So this is my reference slide. Sorry, I had a computer malfunction. I don't know what's going on. So this is my reference slide. This is just the article that I used to kind of get more information versus what was already in the book. And it just went ahead and gave me like some different ways that a respiratory distress system came about, which I mentioned earlier, like a baby can have an infection, that pneumothorax also could cause respiratory distress syndrome. It's just different ways, and like I said, it does affect 30,000 to 50,000 infants in the United States every year. So it is pretty common. Of course, it's more common in premature babies. However, um, it can happen to at least 5% of babies born after 34 weeks. So just because your baby's not considered premature doesn't mean that they can't develop respiratory distress syndrome. So yeah, that's it.